Hello, everyone. I am pleased to introduce someone many of you know already relatively well for her work on mortality because she leads our Danish chair on mortality research, Marie-Pier Bergeron Boucher, Marie-Pier and its co-authors and co-researchers. Marie-Pier is a young researcher, associate professor at the Interdisciplinary Center on Population Dynamics at the University of Southern Denmark. She has been working with James Voppel, who also participated in the foundation life. And she has published numerous articles in various internationally renowned journals. As I said, Marie-Pier is leading a chair on mortality research that tries to answer the pressing questions on how long do we live, with which health conditions do we age, why and from what cause do we die, etc. The primary objective of this chair is to initiate research in the fields of demography and actuarial science applied to the analysis of mortality and longevity. And I insist on that point. We are not speaking here of genetics by definition, of biology, etc., but much more of statistics and behavioral economics. The research conducted under the chair focuses on three main topics: analyzing multimorbidities and causes of this, forecasting mortality, developing demographic models to study changes in mortality. The chair has been launched the 6th of June 2023. Today, we will focus on the multiple causes of this and their consequence on mortality risk. The conclusion of these first research results are very important, I think, for us, at least as insurers, but probably for more person and for social insurance also, etc., as they underline that multicausality is much more informative of the pathway to this and help us to better capture the burden of disease. But at the same time, it increases the universe of mortality risk. But I stop there because Marie-Pier will explain us very clearly and very convincingly these different points. Marie-Pier, thank you so much to have accepted with your co-authors and co-researchers to present us your first results today. The floor is yours, but before, let me remind our auditors that the webinar lasts maximum 90 minutes, so that you have roughly, Marie-Pier, roughly 60 minutes for your presentation and a maximum of 30 minutes for the Q&A session. We, by definition, stop the Q&A session as soon as there are no more questions and no more than 30 minutes, therefore. Dear auditors, I also remind you that except technical understanding questions, you must keep your question for the Q&A session. Please, Marie-Pier, it is now up to you. And thank you so much.
Thank you very much, Philip, for the nice introduction and summarizing what we're doing so well. So we have been very fortunate to receive funding from the SCOR Foundation for Science to study multiple aspects of mortality change. And as Philip mentioned, today we're going to focus on one of the key parts of our research project, which is to look at multiple causes of death and how they change over time, looking at their dynamic as well. So I have two colleagues that accepted to join me today and to present our research result. So we have Cosmo Strozza and Elizaveta Ukolova that also going to present some part of our result today. So hope everybody can see the change of slide. And the plan for today, so I'm going to give a brief introduction of what we mean by multiple causes of death and what has been done so far in the literature. And then we're going to jump in with what we've been doing, including evaluating the accuracy or what information we can have from multiple cause of death analysis, talking about diversification of cause of death, competing cause of death, and the association between these cause, and the effect of multimorbidities on mortality risk. So start with the introduction. So if we first ask the question, why and from what do we die? So that was one of the key questions we wanted to answer with our project. So it's important to understand what do we die from, because at which age and for what we die also relate from to how long we can live. So that's the other end of life. And if we know what we die of, then it might be possible to better find ways to save life and maybe prevent premature mortality. That also could give us better information on the burden of disease in the population. So which disease most burden a population in terms of mortality. So what we've been dying of have been changing over time. So if we think what's happening in the early 1900s, we know that most deaths were due to infectious disease and external causes, and we can include maternal mortality as well into this. However, we died more and more, especially since the 1960s, from chronic disease. So we managed to reduce the risk from infectious disease, and that led to prolongation of life, so we live longer. But now we die mostly of chronic disease. However, even across chronic disease, we are observing a shift in terms of from what we die. So here's just an example. I don't know if you can see the cursor, but we die mostly, again, mostly from cardiovascular disease and cancer. However, when we look at the smaller group of cause, we see, for example, that dementia and, of course, COVID have been gaining importance over time, and chronic respiratory disease and lower respiratory infections are losing importance. So we still observe a lot of changes in terms of what we die. Another question we can ask is, yes, we die once, but from how many causes? So in a population, an aging population, and as we age, people tend to develop multiple conditions. So it's rare that somebody that reach 80 or 19-year-old only have one chronic condition, but often have multiple one. So how are those multiple conditions interact in creating death, or how much do they compete? However, when we look at cause of death statistics, we often only show the underlying cause of death, which is the condition that is considered to have initiated the train of event leading to death. So this is the condition without which death could not have occurred. But when we look actually in what is written on the death certificate, we often see that multiple causes can contribute to one death. And then by looking at only one cause, we can downplay the roles of other disease in the mortality process. And also we can hide the mortality burden of specific disease in a population. So if we first look what the death certificate look like, this is the general pattern. So we can start from the bottom here, and we have the underlying cause of death. So again, this is the cause that is believed to have initiated the train of event that lead to a death. However, we can have also at the end the immediate cause of death, which is the one that terminates the chain of event. And in between, we can have other conditions that are linked to the underlying cause of death and say, well, this one could only happen could not have happened without the underlying cause of death. Then we have a chain that eventually lead to the immediate cause of death. So this is the part one of the death certificate, but there's also a second part where other conditions that have contributed to death but is not directly related to the underlying condition can be reported. So this is also causes that are believed to have contributed to the death without being directly related to the chain of event. So how do we interpret all of this result? So in the literature, there's three main analyses that have been done. The first one is to look at how many causes do we die of. So here in the first graph, we see that actually there's really little proportion of death that has only one mention or one cause reported. That goes as little as 2% in Italy to as high as 25% in the US. But we still see that most of the death certificate has at least two or more conditions reported. We can say also that this pattern change over time, over age. So we see that in most countries, there's a maximum or a peak in the number of reported calls around age 70, 80, and then it decreases afterward. But we have more condition reported on the death certificate at older ages than at younger ages. This also have been changing over time. So this is an example for the US, where we see that over time there's less and less death certificate that report 2 or 3 condition, but an increase, a very important increase since the early 2000s of reporting at least 5 cause of death on a death certificate. This sudden change in trend can be due to the change in the international classification of disease and the possibility to report more causes as well. This sudden change in number of reporting to cause, also from reporting 1 cause only, can also be due to this change in classification. Second type of analysis that we often see in the literature is how much only looking at the underlying cause of death underestimate mortality from specific causes, and the literature has been focusing especially on a few causes. First of all, diabetes. So this is an example for diabetes. So what the graph shows is that if we only look at the underlying cause of death, for example, for female at age 85, there was about the death rate for this age group for female was about 3%. However, if we look at any mention of diabetes on the death certificate, we see that the death rate was actually almost 4 times higher. So diabetes, the death rate diabetes to any part of the death certificate was about 13%, so way higher. This is also true for Alzheimer's and dementia. So if we look at this graph here, also for the US, another example here for Canada, we see that the age-specific death rate per 1,000 people was about around 150 for both female and male, when only looking at the underlying cause of death in the early around 2006, but there was just short of 300 per 100,000 if we account for all mentioned on the death certificate. So actually, this condition play a way bigger role in the process leading to death than we can think of by only looking at the underlying cause of death. This is also true here for sepsis, another cause that has been that has received a lot of attention. So again, you can see this is the trend for underlying cause only, and then you can see the increase in the age-specific death rate, or the age-under death rate, sorry, if you account for all mention of sepsis on the death certificate. The last example is for cardiovascular disease and different type of cardiovascular disease. It might be a little small here, the legend, but basically when we look at acute myocardial infarction, or heart attack, there's not a huge difference between looking at the underlying cause of death or the all cause or multiple cause of death approach. However, there's a big difference when looking at other cardiovascular disease, including ischemic heart disease and heart failure. So only looking at underlying cause of death definitely underestimate their importance in mortality. A final type of analysis that has been done in the literature is looking at the association between causes. So there's some cause that more often paired in the process leading to death. So this is one example. So everything is blue is cancer. So with different cancer, we see that the greater association with unspecified malignant neoplasm and secondary malignant neoplasm in being associated with different kind of cancer. We also see, for example, a big association with diabetes and obesity. So the take-home message from all of this analysis that have been done so far is that the underlying cause of death only represent the tip of the iceberg when we look at cause-specific mortality, and that multiple cause of death analysis can better capture the role of specific disease in the process leading to death. So in the next part of the talk, now we're gonna show what we add to the debate and move a bit beyond what has been done so far. So I'm gonna let Cosmo now talk about the accuracy of multiple cause of death.
Yes, thank you, Marie-Pier, and hi everyone. It's a pleasure to be here at the SCOR Foundation seminar. I thank Marie-Pier especially for giving this great introduction and opening the floor for my little bit of the presentation. So she just mentioned that multiple cause of death data are the tool that we can use to move forward from what has been done so far in the research on mortality. But then the question arises here, and is whether multiple cause of death data are representative of the health conditions at the end of life of an individual. Well, the short answer here is no. And then when me, Marie-Pier, and Betty here were discussing this issue, then we were trying to move forward and ask whether they at least better represent what is the chain of events leading to death. And in this case, the answer is maybe. And today I will show you some preliminary results that we have obtained so far to answer those two questions. And to do so, we use Danish registry data. So we use mainly two sources of data, which one is the cause of death register. I'm also very grateful to Marie-Pier, who introduced what is a death certificate and how causes of death are registered in a normal setting. And in our case, we obtain those information via the cause of death register. So we have all the information on the leading cause of death, the contributory causes, and then the co-causes, the secondary causes that Marie-Pier introduced. And then together with this, we use a register of chronic diseases, which includes all the individuals that during their lives have been diagnosed with COPD, dementia, and diabetes. When I say diagnosed, I mean that either they went to the hospital because of one of those three diseases, or they have been prescribed and they have taken a medication for one of the three diseases. So it's basically a register that combines two sources of information: hospitalization and drug use, medications. Then with these registers, we come up with a study population, which is the Danish population diagnosed with one of the three chronic conditions I just mentioned. And for the time being, we focused on the years 2010 onwards up to 2019. This is where the data have the highest quality, according to Denmark statistics. And we focus on individuals who are 50 years and older. So for them, we know about their sex, when they were born, the date and the age at diagnosis, the date and age of death, and finally the cause of death. And then here I would like you to remember what Marie-Pier showed you, that there are these two parts of the death certificate. And when you see one, A to D, that's the first part. So the chain of events leading to death, with the lowest representing what is the underlying cause of death. And then there is a secondary part, this 2.1 to 2.4, which is the secondary causes that did not enter the chain of events leading to death. As I mentioned, it is a preliminary analysis, so there is a very descriptive part that we run. And in particular, we look at the number of times each chronic disease appears on the death certificate of an individual. So we know that people have those diseases. What we are interested in is whether the death certificate actually represents what are the health conditions of an individual. And we do this for the whole study population. And we also do it for a subsample of those who died within a year from being diagnosed a chronic disease. Then for those who have the chronic disease reported on the death certificate, then we look where this chronic disease appears in the death certificate, whether it is in the first part, in the second part, where in which location it is placed on the death certificate. Finally, we also look by cause of death, whether the disease is reported or not on a death certificate of an individual. So we will distinguish all those who died by cause of death and then rerun the first analysis that I mentioned. There is also a more analytical part that we have run for now, and this is running multiple decrement life tables. Those life tables are computed by sex, by period. We put together 2 years, so 2010-11, and then we do it by period until 2018-19. We do it for the 3 chronic diseases that I mentioned: COPD, dementia, and diabetes. Even though today, for the sake of time, so I'm not taking too much of your time, I will focus mostly on dementia and diabetes, who were also mentioned by Marie-Pier in her introduction. And we look at 17 different causes of death, which were categorized according to the human cause of death database. It's this standardized database that compares cause of death data for multiple countries. And the main outcome of the multiple decrement life table is basically known of a specific subpopulation, whether this, like, what are the main cause of death of which this subpopulation dies. So we will have a percentage, a prevalence of deaths attributed to one cause rather than another one. So I will start with results for dementia. And yeah, I would simply describe what you see here. There is a left-hand side of the slide, which is the total study population. And here we are looking at, in the top left part, among those who have dementia as a chronic disease and died, how many of those had dementia reported on their death certificate? And this is 55.2%. So a little bit over half of the deaths of people with dementia have reported this on the death certificate. When we move to the bottom left part of the slide, we see the placement on the death certificate. So among those 55.2%, so among the 24,000 deaths, we can see where these were located on the death certificate. And if we focus on the 1, A to D, and 2, 1 to 4, as in two groups, we can see that it's mostly half-half that dementia appears in the main part of the death certificate or in the secondary part of the death certificate. And we have run the same analysis, and here we move to the right-hand side of the slide, for the subsample of those who die within a year from diagnosis. In this case, we can see that the percentage of those who have dementia reported on the death certificate is lower, is 40%. And we also see that in this case, is a little bit more frequent that dementia is reported in the secondary part of the death certificate, so between 2.1 and 2.4. But of course, we know that dementia is not something that you get and it leads to a quick death. It's rather something that people have for many years during their later stages of their life. If we move to the next slide, we can see the results of the multiple decrement life tables. So here, as I said, the main outcome is to see what is the proportion of deaths for each of the causes of death that we analyzed. And here, it's only reported the 3 leading causes of death for people with dementia. And it is heart diseases in yellow, mental disorders in green, and diseases of the nervous system in purple. You see that the values are by period, so you see the different years, and you see the women are on the left and male on the right. But you also see something else. There are solid dots that represent the proportion for the subsample of people with dementia. And then there are the circles, which are empty in the middle. This is the total Danish population. So we are here able to compare the proportion of death by each cause for the subsample of people with dementia and the total population. And we can focus on the mental disorder, which is the highest, which has the highest proportion for both men and women, but also the nervous system disease. We can see that they are both higher than the general population for those with dementia, and also that there is an increasing trend over time that we see here. While when we look at heart disease, we see that, especially for women, but also for male, there isn't that great difference with the general population in terms of how many people die of this cause of death specifically. So in the next step, what we did is looking at all the causes of death, but specifically focusing on those 3, because they are the 3 leading causes of death for people with dementia, whether among those we can see actually dementia reported on the death certificate. And you can see that for mental disorders is almost always reported on the certificate, but it's also very high percentage, 84% for the diseases of the nervous system, that we can see dementia reported on the death certificate. Here I also have to say that for those people, most of the times it was dementia actually the leading cause of death identified by the medical doctor. So it is, of course, explaining this very high percentage of appearance on the death certificate. Now I have a small question for Marie-Pier. Can I continue for a couple of minutes over 10? Is that fine? So I present also the
diabetes. You can present diabetes, no problem.
Thank you. Yes. Because for diabetes, we see quite contrasting results from what we just seen for dementia. Now we have learned how to read these tables, right? So if we go straight away to the left-hand side, we see that only 14% of the times that people have diabetes and die, it's reported on the death certificate. And this is mostly as a secondary cause. It's never as a leading cause of death or in the main part of the certificate. And this doesn't really change too much in terms of how many times it appears on the death certificate if we look at those who die within a year from diagnosis. But what changes is where diabetes in those 13% of the times appears on the death certificate. And this is to a much more a greater extent in the main part of the death certificate rather than in the secondary part. You can see the 1 point D is almost 50%. So this we thought was something quite interesting to observe. But then if we look at the results of the multiple decrement life table, we see now that the 3 leading causes of death are endocrine diseases, heart diseases again, and neoplasms. But the first thing that we notice now, we know that the circles are the general population. So for instance, for neoplasms, we see that the proportion is lower than the general population for both men and women with diabetes. What it is higher is actually deaths for heart diseases, it's consistent for men and women, and endocrine diseases, consistently for men and women. If you want to read one of those numbers, for instance, endocrine disease, you can look at the female, and overall, the study period, we can see that it's not even 5% of the daily rise of this specific disease, while it is around 10% among those with diabetes. So it's twice as much. And similarly, you could read heart diseases here. So if we move to the final descriptive result and look at the 3 leading causes of death for those with diabetes, we see that actually the percentage did not increase very much from the 15 general value that we saw before. Maybe for endocrine disease, 1 every 3 times that a person dies and has diabetes, it's reported on the death certificate, but the result is not, striking or outstanding. So to conclude and to remark what was anticipated before, multiple cause of the data cannot really be used as a proxy of individuals' health conditions at the end of life. At most for dementia, we see that, this has a higher appearance rate on the death certificate. Definitely not for diabetes. But it seems to be more better suitable for understanding the chain of events leading to death, especially, when you look at cause of death that is really associated with what is then leading a person to die. And it is, what you see, for example, in the dementia cases, when looking at the leading cause of death, there is a very high appearance there. But this is not the case for diabetes. Diabetes is a very different outcome here. Is a preliminary analysis, so we have next steps here that we will work on in the coming months, which is to investigate more empirically what is driving the probability of appearing on the death certificate of one chronic disease. We can do it by the age at death, age at diagnosis, the time passed between diagnosis and death, as well as cause of death, of course. So we will do it more empirically rather than just showing these descriptive results. We will also include confidence intervals for the multiple decrement life tables so that we can see whether the trends that we observe are actually statistically significant or not over time across sexes and diseases. And finally, and this is the most important part, we will also analyze cancer data and hospitalizations caused by health shocks. And here we expect to see different results from what we have seen with the chronic diseases that I just showed. And for instance, for cancer, we could expect that some more lethal cancers might appear much more often than others that, for example, are, when they are cured and it's quite some time has elapsed since the first time the person has got cancer, maybe there would be a lower rate of appearance then. And for health shocks, we might expect a much higher rate of appearance overall. But thank you.
Thank you, Cosmo. that's the first part of our result. And I'm going to move to the second one, which is discussing cause diversification. So what do we mean by that? So historically, we used to have one or two major group of causes. So, for example, before it used to be infectious disease, that was the leading cause of death, and then we shift to cardiovascular death and maybe cancer. But a few studies observe that as we go, we are a bit losing this principle of one or two big causes and moving more towards smaller group of cause. And this is called diversification of cause of death. So that's basically saying that cause of death profile is becoming increasingly complex. So that has some implication. So first of all, that can lead to a lower predictability of the cause of death. So if we give an example, for example, that if we only have, for example, two causes of death, let's say cancer and cardiovascular disease, if 90% of the death are from cardiovascular disease and 10% from cancer, then that would be very easy to predict which will lead to a death, but also that would be easier to predict for, or that would be easier to fill the death certificate and predict the correct underlying cause. More complex cause of death profile can also lead to more fragmented effort to reduce mortality. So instead of putting all the resources in one basket that you have to cure one cause if you want to improve life or reduce mortality, then we have to divide more of these resources across multiple smaller causes. But most of the study of cause diversity are generally only analyze the underlying cause of death. So again, that can only represent the tip of the iceberg when we look at complexity. So in one of the paper, we wanted to estimate cause diversity accounting for multiple cause of death. So here we can think of two different dimensions of complexity. First of all would be the number of cause. So this is one level. So how many cause do you have to treat in an individual to save a death? And the other one is the relative abundance, and it's more like the standard cause diversity that I just mentioned. So how equally spread are the death across the group of cause? Are most death happening in one cause of death, or are they equally spread across multiple one? And this is generally measured with diversity measures like the Simpson Index and the Shannon entropy. But we also had a bit more of a philosophical question on how to integrate multiple cause of death into this framework. So should we consider every cause reported on the death certificate equally if we want to treat, if we want to reduce a death, or should we give more importance to the underlying cause of death and see every contributing factors as just adding complexity to this initial level? So we came up with a framework to estimate MCODs for multiple cause of death diversity that account for all aspects of diversity. And we make sure that all the indicators we came up with can be decomposed. So that means that we can understand why they are changing over time. So if we look at the first dimension, which is the number of cause. So we had data for Denmark, France, and the US, and from around 2000. And we see that for all countries, we have this increase in the number of reporting cause with a sudden jump during the COVID pandemic, especially strong for the US. So if we wanted to understand why do we observe this increase in the number of cause? So we can decompose the change between 2006 and 2019, so just pre-COVID pandemic, and this is the common period for all three countries. And we say, well, are we observing this increase in the number of reported cause because population is shifting towards higher ages, and at higher ages we tend to have more reported cause, more numerous cause of death. And what we can see from the first column here is that change in the age at the distribution does not have a major impact in the increase in number of reported cause. Then we look is, do we observe this increase in number of cause because we're shifting death towards underlying cause of death that come with more contributing cause, so with more other mentioned in itself. And this is the second column, and we see that this there's a bit more impact, but tend to be negative, but still pretty small. So and then the last factors, they say, well, is it just that we observe a general increase in the number of cause across all ages and underlying cause of death? So we see these underlying cause of death, and that seems to be the case. So there's a general increase in the number of reported causes across ages and underlying cause, which can be can be a change in the number of morbidities people have, but also the way we report them on the death certificate. Then for the second part, we look at this relative abundance index using the Gini-Simpson index. So the higher the curve, the higher the diversity, or higher the complexity, the cause of death profile. And then we compare the trend if we look at the underlying cause of death only, and if we're looking at multiple cause of death, assuming that all causes contribute equally to diversity, no matter the position on the death certificate. So here we see that indeed, when you account for multiple cause of death, we have a way more complex profile. However, and this trend has been increasing over time. However, there's a convergence between multiple cause of death and underlying cause of death on the approach. This also can be decomposed. So here we can see what mortality change from which cause drive this increase. So if diversity can increase in two ways. First of all, we can reduce mortality from major group of cause. So that would increase the mortality pressure on smaller causes. Or we can increase mortality from smaller causes, and that would, I'm sorry, it was increase cause. Okay, sorry, there was a question. We can increase mortality from the smaller cause, and that would again remove a bit of pressure on the big cause. And this is the result we have. So for space reason, I only present Denmark and France, but it's a similar result from the US. So sorry for the abbreviation here, but briefly what we see is that increase in diversity is first and foremost driven by reduction in mortality from disease of the circulatory system, which is the major group of cause. This is also true for France, and it's true for both underlying and multiple cause of death approach. We also see some that reduction in cancer mortality also have an impact on increased diversity for Denmark, but not as much for France. And also increased mortality from mental and behavioral disorder here and disease of the nervous system also contributed to increase diversity, especially in Denmark, a little less for France, and mostly with the underlying cause of death approach. And then we have one last curve. So as I mentioned, I have two ways of seeing multiple cause of death. So the first one is that every cause mentioned in the death certificate have the contribute equally. The other one is that we see the underlying cause of death as a minimum diversity. And then every time we add a contributing cause, we add to this complexity, and the more diverse what this contributing cause, the higher the diversity. So the second approach here, this M2, is more sensitive to the number of reporting causes over time. And we see that this shows even higher diversity. And also we see very minimum discrepancy across countries. We can, interestingly, if we look at the relative increase from the first year between the M1 and M2 approach, they have the same relative increase over time, except for France, that has a bit more leveling off in the M1 approach. The M2 can also be decomposed. So this time we can see why is this indicator of diversity increasing. Again, is it because we shift death towards underlying cause that have more diverse contributing cause of death? Or is it that we observe genuine increase in diversity across each underlying cause of death? So it seems to be a half-half scenarios in most cases. So we do tend to shift, mortality tend to be shifted towards underlying cause of death that has more diverse contributing cause of death profile. But this, for each underlying cause, is also an increase in how diverse are the contributing cause. So the take-home message is that the cause of death profile is becoming increasingly complex across countries due to both an increase in the number of reported cause and the increase in the complexity of the relative abundance of the cause. So would that mean that it's going to get harder and harder to keep improving life expectancy if we have to reduce mortality across more diverse set of cause? And would it make our life also harder to predict cause-specific mortality if we need to better understand how deaths are shifted across multiple causes? So this is part of the topic for future research. And then I'm going to keep on going with competing cause. So there's two way we can there's two way multiple cause of death can talk to each other. So cause can compete to be the underlying cause of death, or they can interact. So they can get combined in leading to specific risk. So we did some analysis in both direction, and Betty will talk more about association between cause of death, but a first word on competing cause. So we know that throughout life, individuals are exposed to multiple risks, while the occurrence of one can prevent the other. So this is known as a competing risk. So in cause of death, we can talk about competing cause of death. So if you die from one cause before, then you cannot die of another one. So then we ask, what is the probability that you die from one cause? And here would be the underlying cause of death. So what is the chance that one cause is more reported as underlying cause of death before another one? To do that, we do a pairwise comparison across 10 different group of cause. So here, let's start. So this is an example for the US in 2015, 2019. And if we look at what's the probability that you die from disease of the circulatory system before any other cause. And this is looking at underlying cause of death only. So this is more like a population-wide analysis. So as a population, we have a higher chance of dying of disease of circulatory system before anything else. So here the graph, basically if we have a 50-50 chance, so this black line, that would mean it's a toss of a coin with cause of death would get to you first. And if it's positive, that means disease of circulatory system has a higher chance of being your underlying cause of death than anything else. However, this can represent that this disease is just more prevalent also in the population. So then the next question is that we look at multiple cause of death and asking if you have mentioned, these two mentioned on your death certificate, what is the likelihood that disease of circulatory system gets to you first? And then we have a different pictures. So once we know that individual has multiple disease and they both mentioned on the death certificate, then we suddenly see that basically the risk of dying of disease of circulatory system before disease of the digestive system is 50-50. It's a coin toss. And this is true, like the probability of decrease for most causes. And we also see that suddenly, if you have both disease of circulatory system and disease of the nervous system, you have a higher chance of dying of disease of the nervous system, or this is a higher chance of being the underlying cause of death. This is also true for cancer and external cause. So then let's look at one last graph, which is what's the probability that you die of disease of the nervous system first compared with any other cause. And this is higher. So if you have disease of the nervous system and something else, it's most likely that disease of the nervous system will be your underlying cause of death. So this is still a preliminary result. So there's more to come. So I'm finalizing the result also for Denmark, and I hope to include also more countries. And so far we have very similar result. So that seems to be consistent across countries. And because we do have access to this great data in Denmark, I also want to look. So here I'm only looking at the mention on the death certificate, but for Denmark, I can also look at the disease history and look at people that has the disease. What is the likelihood that one be your cause of death before the other? And also compare that with the result we obtain from the multiple cause of death analysis and see if both are consistent. So if both are consistent, that means that we can probably do more. That might be easier to do this kind of comparison across countries. So I'm letting now the place to Betty and talk about cause association.
Thank you, Marie-Pier, and hello once again. As Marie-Pier just said, there are these two key frameworks, how we can frame the causes of death. So the one is the competing risk, and the other one is assuming that the death would not happen if some of the set of the causes would be missing. And I'm now taking this second approach I just mentioned to investigate sort of like these relationships between causes. But firstly, let's start with what we know. So there is a known structure of associations between major groups of causes of death. Here on this slide, we can see in red these associations that if you have one disease, there is a higher chance to get another one. And this is especially true for infectious diseases or for diseases of skin and subcutaneous tissue, or some metabolic diseases, and so on and so forth. In the other slide, we have a more closer look to the US data, where you can actually see the numbers, so how the risk of having both increases when you have just one. So again, as I just said, for infectious diseases, it is especially the case, but also for diseases of blood, and so on and so forth. And this structure of dependencies somehow evolves over time. Here you can see for 10 leading pairs of disease groups, how it evolved starting from the year 2000 up until 2019. So this is what we know, and we wanted to have a look a little bit closer to the synergy of diseases. And what we did, so as you might remember, Marie-Pier introduced the death certificate, and there is this chain of morbid events, and then there is this contributory cause of death, which has actually quite a vague definition. It is just not a part of this chain, but we don't know whether it is a necessary condition to move through this chain, or whether it is just there, but it does not have any significant relation to this condition in the chains. So we focused on modeling the interactions between three diseases always. So we selected the leading triads, and we were modeling the synergy between three diseases and focusing on interpretation of the role of these contributory causes of death. For that purpose, we were using the causal pi models. Here you can see so all possible mechanisms that we were assuming during the modeling. So the first one, the model one, is actually what you would expect if the death certificate would be filled in properly. So the underlying cause of death might lead to some other conditions, to this immediate cause of death that then directly results to death. And then there is this possibly mediating condition, the contributory cause of death. But we don't know anything about this relation of the contributory to this chain. So we are using these all models, and we estimated the parameters. Now the procedure or the method is a little bit not that straightforward. So just to keep it simple, with the help of conditional probabilities, we could estimate there are 6 different pathways how one can travel to this immediate cause of death, which then directly results to death. So for example, in the pathway 2, you could see that actually contributory cause of death is a necessary condition to make this transfer. On the other hand, pathway 1, the contributory cause of death does not enter this relationship at all. So we were estimating these parameters, and with their help to make the interpretation easier, we were calculating attributable fractions. And attributable fractions, these are the proportions of people who follow different mechanisms. So if we see on the other slide, this is just an example how the estimation was done. So basically, if the most easiest example, probably looking at the panel D, that if you have a person who only had this terminating condition and did not have the other 3 in the triad, then he or she must have obtained this condition outside of the mechanism. So the population attributable fraction would be 1 in this case, in this particular pathway towards the immediate cause of death. And in others, of course, it is more complicated when people have all 3 conditions. So we estimated the attributable fractions, and the results are shown here. So in the columns, in the first, in the second, and in the third columns, these are the leading triads of diseases we had. CC, this is the contributory cause, UCD, it is the underlying, and then non-UCD, it is this terminating condition. And for each of this triad, we have the best model. So the most likely scenario of the synergy between all three diseases. We did it separately for males and females, and for younger age group and for older age groups. So the younger ones are the death younger than at 80 years old. And based on these results, we could distinguish the contributory causes of death to have three different roles in the process of death. So the first one, it is that they actually are indeed mediating this chain of morbid events leading to death. This would be especially true for chronic kidney disease and for this atrial fibrillation, because as you can see, the dominating pathway is the pathway for example, model 1. And here on this slide, you can see that pathway 4 shows that there needs to be this synergy, this interaction between both diseases to enter the final condition. The other type of contributory causes of death, it is the one that actually don't have any significant relationship to the chain, of course. This would be especially true in the older age group for chains where contributory cause is dementia. Because in such cases, mostly we can see that the best fitted model is the one where pathway 5 occurs. And the very last group of contributory causes of death, it is those where actually the mechanism is like that you need to have contributory cause in order to develop the whole chain. So actually this contributory cause is the necessary condition to get your underlying cause of death. And this is especially seen in examples of diabetes, because we get the best models or the highest attributable fractions for pathway 4 in models 3 for diabetes. So if we move to the conclusion of how to summarize the result, here are these three different types of contributory causes I just mentioned. And furthermore, there is always also like more detailed result that these interactions, this synergy, it changes by age. So in younger age groups, there is this higher synergy than in older age groups. You could see more like independent operation of diseases. And why is this important? Because there is a huge difference in age at death for people depending on whether they have or they don't have the contributory cause of death. And therefore, it is actually quite important to understand how this process of death is happening, because the contributory causes of death are differentiating factors in mortality risk, basically. And the other part that I would like to talk about today, it is that a paper we were working with Cosmo, and it is about the effect of multimorbidity on mortality risks. In this case, we were working with Czech data. And just to give you a little bit of a context about Czechia. So Czechia is the most multimorbid country in Europe. When you look at the proportion of people who report they have a multimorbidity, it is as high as 60%, which you can't find in any other country across Europe. Also, Czechia is one of the first countries in Eastern Europe which has available and quite high quality health registry data that you can use for the purpose of the analysis. And we know that there is this gap between East and West Europe in life expectancy. So we can now actually see whether this is due to different multimorbid patterns in these populations or not. So we were using this data, and we were focusing on development of mortality by multimorbidity in the last decade. Here on this slide, you can see just the descriptive measures of the burden of multimorbidity. So the panel 1A, it shows the distribution of people by number of chronic conditions they have by age. So for both periods, starting from the age of 60, most people have at least one condition, and then at age 80, it actually transferred that most people have at least two conditions. And what is interesting that you can see that in the year 2014, there were considerably more people having at least three conditions compared to year 2022. So from all of these diseases that you can see here, we were selecting leading chronic conditions and leading combinations of these chronic conditions. So this is quite rare. It's not that often done that we don't just focus on risk of mortality with one condition, 2, 3, and so on, but we were actually differentiating by the diseases that are being combined. And on the next slide, this is the mortality risk by age. So as expected, the more conditions one have, the higher is the risk of death. But there is this huge variability by combination of diseases. When one of the diseases is neoplasm, the risk is usually higher compared to when one has combined, for instance, diabetes and COPD, then the risk is rather low. So the effect of multimorbidity of this risk elevation is not that pronounced. This result is for the second period, and if we compare it with the first one, we see the result on the next slide, where we show the ratios of the mortality rates in the 2040 and 2023. So if the curves are above the level of 1, it means that the mortality increased during that period, otherwise it decreased. In diabetes, it is mostly the case of increase of mortality, while in neoplasm, it is the opposite. And for other diseases, there is this irregular, very much in the age-dependent pattern that you can see that in certain age groups, we see the decrease of mortality, and in other ones, it is the opposite thing. So this was to the change, and final step in the analysis was to look a little bit at the factors that could contribute to this change in mortality of people who have some chronic conditions. For that purpose, we were doing decomposition. We are decomposing the crude death rates of people in major chronic disease groups. And here are the results. So we were distinguishing between age effect, multimorbidity effect, and then there is this pure rate effect. Between these periods, mostly mortality declined, and this was due to multimorbidity effect. This means that the composition by number of diseases in these groups changed. And if you remember, I showed you that actually after COVID, there were much less people having 3 and more conditions. So it could be a rather effect of COVID than of actually, the Czechs are getting better with their health. Because we can see that the rate effect is positive, it means that if the composition by morbidity, by multimorbidity would not change, then the overall mortality would have increased slightly. This is the case for all 3 diseases, or all 4 diseases except for neoplasm, where the rate effect is negative, as you can see here. So to wrap up what was found in this paper, so there is this gradient with the more conditions you have, the highest is the risk of death. But one has to distinguish which conditions are those, of course. And regarding the development, it seems that the mortality of people with multimorbidity is decreasing, but this might be in case of Czechia quite misleading, that this is a long-term trend, and it might be rather the effect of COVID-19 that took lives of people with extremely complex multimorbidity patterns and with bad health, so they could not contribute with this with their mortality in the years after COVID to the overall population mortality. Because overall we saw that the rates effect were actually positive, implying the increased mortality of of people with chronic multimorbidities in Czechia. So,
thank you, Betty. And so we're already at the end of our time, so I'm just gonna make a conclusion of we went in different direction and everything we've been doing, but just to wrap it up with the main message is that the pathway to death is increasingly complex. So there's multiple factors that contribute to one death. But even despite this high complexity, multiple cause of death still undercount the number of conditions present at the end of life, as Cosmo show you. So death certificate or multiple cause of death data represent the pathway to death and not all conditions present at the end of life. And then we discussed that the cause of death can compete to be the underlying cause of death, but they can also interact in leading to specific risk. And we show that having multiple conditions, as Betty showed, increase the mortality risk. We found that multiple cause of death are informative of the pathway to death, but looking at the multimorbidity, so not just how many causes are mentioned on the death certificate, but the full morbidity history would capture even better the burden of disease. And this is ongoing research. This is the next step of the project to dig deeper into this perspective. So thank you very much.
Thank you very much, Marie-Pier. Thank you, Elizaveta. Thank you, Cosmo. And of course, let me turn immediately. We have first question which have been sent in a message. I have first a question of Colin Kearney. Perhaps, Colin, if you are already connected, maybe you could
he has
explain
just left, Philippe. He has another meeting.
So he has another. That's why I have to read it. Then he said, okay, thanks for a valuable presentation. Hope this question is not premature and maybe you will cover it. There was a lot of focus during COVID-19 in understanding the approximate cause of this, i.e. COVID itself, or combined with comorbidities or other cause. In your opinion, has his experience of the COVID improved in any way the accuracy registering of the correct cause of this on these certificates?
Cosmo, you want to answer this?
Yeah, I read it right after I finished presenting, okay. And it's quite it's a very interesting question, and I think we didn't look at it explicitly yet because we focused on the data that were, according to the statistics Denmark, the most valuable, which is 2010, 2019, because then COVID comes and then we don't know whether the data are of the same high quality or not. We have to test it. So I think we will simply expand our analysis to get to the latest year we have and check whether this improved or not. So we don't have an answer. I don't have an answer. But we will definitely include, like it is in our minds to include, of course, all the possible years we have available into our analysis. And then we can maybe make a specific appendix for the COVID period just to see whether we see any change in the trends that we see over time in terms of accuracy of the registration. So no answer yet, but it's in the pipeline.
Okay, fine. I have two questions, or maybe one question in two, of Regina Rosate. Regina, would you like to ask your question yourself, or do you prefer I read it?
I don't know that it's a question. It's just a comment on.
Yes, make it.
So I am a physician in the United States. I'm the medical director in the US. And so I wrote two parts here. I would guess that the increased causes of death over the time period might be because during that period that you look from 2006 upward, the online resources were developed and improved. Okay, so death certifiers may have had more direction in filling out the death certificates. Because I can tell you in the US, in every place where I have worked, physicians in the hospital fill out the death certificates. Okay, for those who die in the hospital. We receive zero training in this. Okay, and often the person with the least training in the room ends up filling out the certificate. So I have been in the room many times being told, you're filling out the death certificate. And I would stand there going, what should I put? And they would just like yell out things. And I was always taught everybody dies of cardiorespiratory death. Everybody does. So everybody can say that, because if your heart's no longer beating, you're dead. That is always the cause of death. That is the amount of training that I had. So whatever else you put really doesn't matter if there's no knife sticking out of them, kind of thing. So I have to wonder, do people in other countries, are they trained differently? I know that in the US, if somebody dies at home and they were not ill and they hadn't been seen, then it's supposed to go to a coroner or a medical examiner. In the US, those are often elected positions, and they do not have to be physicians, nor do they have to have any training. They may take a little online course. And I know in some jurisdictions, there are like EMTs who are filling these out. So emergency medical technicians. So knowing all of those things, whether somebody calls it the main cause of death or a contributing cause of death, I don't know what it means. So that's why I wonder if training or whatever agenda is being pushed, not even that it's an agenda, just say it would be better if you put more causes of death on there, then they try to put more on, Do you understand? That's kind of my comment. So I'm not sure how it happens in other countries though.
Yeah. No, this is definitely a point. This is true that for most countries, it's the medical doctor that have to fill the death certificate. Mm-hmm. And this is one of the biggest criticism of analyzing cause of death data, and especially underlying cause of death. Because which one is the most likely, which cause most likely started the chain of event leading to death? So this is, so there was a lot of criticism that often it's a bit of a random guess. There was some effort, so there's now automated system that is applied in most countries, and I think including the US, that it goes over the death certificate, and then the system kind of redistribute what was the most likely underlying cause of death to try to make it more consistent also across physician filling up the death certificate, but also probably across countries. So I think in US and Denmark, I think it's the same system. I think in France is a different one. So no, but definitely this is one of the main criticism. And now one of the things we wanted to look with Cosmo is also, if we're looking at multiple causes of death, do you have a better picture of what's happening at the end of life? And even that seems that it's only a sample of what's happening. So it's an extremely different, complex question. But no, I agree with you. It's and I'm not sure how every country is training, if they are training physicians. So I don't think it's a systematic approach in a lot of countries. I think they just rely on this automated system now. Oh.
May I add one little thing, and I would like to ask Regina about this, because in Denmark, for instance, and that's where also our question came from, for every patient, when you have the patient in front of you, it's all digitalized. So you know everything about the patients, all the diagnoses that they had. But of course, in the moment you are registering a death, none of the physicians is going back and looking at what they have and, to make a better guess. I think they're so busy, and, they have to do other things. They have other patients, so they put their guess rather than going to look through, even though the digital system is there and it runs very well. Yeah. Is it the same in the US?
Yeah, they're filling it out to the best of their knowledge. So for instance, say somebody has cancer and they die suddenly. They may have had heart disease too, but that never had been looked into. Everybody doesn't, you don't know, right? So if they died relatively suddenly, was it a PE? Was it actually a heart attack? Was there a stroke? They had a diagnosis of cancer. And again, from a doctor's standpoint, you look and you're like, it's not going to change anything with this patient. They're still dead. They don't worry too much with that. because of time limits that we have in trying to care for patients, you know, they're like, it was a natural cause of death, so they're not overly concerned. You know, they don't know if their hypertension was well taken care of. Maybe these people had type 2 diabetes and didn't realize it. You know, like there's all sorts of different contributors that could have been going on. So.
Okay, thank you.
Thanks. Yeah. I'm going to make a bit of advertisement also for another paper from Betty that is coming up, that she's trying to look at cross-countries comparison in very different countries. So we have Czechia, Denmark, and the US, and see like how are death reported on the death certificate, and see if there's any consistency across country that would kind of a bit eliminate this. That would say that the bias might not be as strong as we think, but if we find something totally different across country, that means like the practice is so different that the cause of death might be like very unreliable at some point. I mean, they still given some information about which disease, like still given important information on the burden of disease, but then how good is this explanation on the pathway to death? So more to come.
And actually, if I may add, that we find that it is quite a very similar, you know, these changes in time and the patterns in Denmark and in the US, but in Czechia it is totally different thing. But it is also because the Czechia does not have this automated coding system, or it was implemented only in 2012. So yeah, so this is the thing. And also I would be very careful about, you know, linking this morbidity and mortality. Then mortality is probably not aimed to represent your, you know, experience of conditions during the life. So yeah.
Okay. Let me look if there are other questions, please. If you can raise your hand if you have a question. I am sure you have a lot, because it's at the same time a very simple question you are confronted with, but we are discovering it's highly complex. Here I see Isabelle Prolion. Perhaps you could connect and ask your question yourself, please.
Yes, please. Thank you very much for the presentation. And yes, I wonder if when you do the diagnostic of a disease, during a long period of time, maybe the conditions of the diagnostic can change or not. Is it the same, I mean, in 2000 than in 2025? Or normally it should change. The tables, the medical tables of the diagnostic can change. So have you an idea of the way we can either modelize that or take that into account, especially when Cosmo in the accuracy, I mean, in the Cosmo part, I mean, what is I mean, an error of the measure of the diagnostic, or what is the change? I don't know.
Just to precise, I'm not sure I understood perfectly the question. Is it more like how diagnostic for one individual change? For example, cancer, people can have cancer and then they can be in remission, or it's more a question about how we diagnose people over time that change, like the practice itself that change?
The practice.
Okay. So this is again a big debate about this international classification of disease, that they change it every few years, and then suddenly there's new disease and there's new what do you call this? So the biggest example is Alzheimer's disease, that used to be like very little reported a few years ago, and then suddenly there's bigger awareness, there's better understanding of the disease, and it's suddenly also better represented in the ICD coding. So we have this massive increase, I think, since the 70s of Alzheimer's disease, but does not mean that it was not there before. This is extremely hard to control. because it's hard to see who really had Alzheimer's disease based on a code that was not existing and a disease that people was just not reporting. So there's a group actually in France that tried to reconstruct like longer time series for the disease and trying to account for this change in ICD. But even that is extremely complex. And another example that's between the ICD-9 and ICD-10, which is the one that is currently in practice, there was a way that they perceived pneumonia. So before, pneumonia could be more of an underlying cause of death. And since ICD-10, it can mostly just be reported as contributing cause. So then there's a massive decrease in mortality from pneumonia from one year to another. And then this death has been reported, like death that used to be from pneumonia is now from multiple smaller causes. So it's really hard to adjust for this jump in perception. However, now we only work with data from the same ICD classification. So that has been in place in Denmark since 1994. So that avoid a bit this sudden jump in our analysis. Does not mean that we don't have like ongoing change in practice and how medical practitioners are reporting the death. But at least it's nothing that is like very sudden, or maybe it's going to be more like we can maybe observe it on a more long-term trend, but I don't think we observe anything in the period we have. Cosmo?
I mean, not much to add, but you said most of the things I was thinking about, except that in the diagnosis one, what we can see, for example, we see it for dementia, there has been the introduction of medications. It was in Denmark, it was at the end of the 1990s. So since the early 2000s, you start to see more diagnosis, and that's linked to the fact that people were starting to receive the drugs. Therefore, they appear as being diagnosed of dementia. And then slowly, what also changes is the policy through which you assign, you give the medication to the people. So instead of only those who are already into a very advanced stage, some policies start to make it before that. So when people have still a rather mild or less severe stage of dementia, then they receive the medication. So then we might see, an increase in the prevalence again of the dementia diagnosis. So there are those little things that, I mean, we can take them into account. Yes, we can. Yeah, we are conducting a separate study from this on dementia itself, and we are looking at age period and cohorts effects on the incidence rates of dementia. And the period is, of course, a big influence, especially we see it when there are those policy changes, then we see an increase. So we can sort of control that to see, for example, how the age effect, so the age at which, dementia appears, is influenced, cleaned up of the period effect. So we can do this kind of analysis, and we are doing in a separate study one of those for dementia specifically. So that's a way to to control it from the diagnosis point of view, from the morbidity point of view, from the cause of death. Marie-Pier already clarified.
I'm just looking if there are other questions. Hand raised, please don't hesitate. Then maybe. Oh, okay. Okay. Do you want Cosmo to add something? No. Okay. I have just one peculiar question. I am not sure to have well understood your table 25 because your slide 25 and the other descriptive table describing the certificate of this. I don't know what is, I have not understand what is the placement on this certificate, what is 1A, 1B, etc., etc.
So here you have two parts of the death certificate. There's the main part where there is the chain of events leading to death, which is 1A, B, C, D.
This is the what is it? It is inside. It's a paragraph of the certificate.
Yes, is that Marie-Pier showed before. Maybe you can show it again, Marie-Pier.
Yeah, I'm
You
going.
showed
It's a lot of slides. I'm going.
Sorry, I have.
No, that's
Here, sorry.
No.
Here.
Okay.
So in Denmark, you can only have 4. You don't have an E, but you have 1. So this is part A.
Okay, I see. This is related to this slide. I just, sorry,
Yes,
I made a confusion and was not, okay.
And part 2, you can have max 4 also cause reported.
Okay. It's directly, because I did not see the 1, and therefore here it was Roman 1 and thereafter. Sorry, it was my, just a remark or a question. The second question, therefore my impression just, going out of your presentation, I have a lot of suspicion on all the statistics I have been reading, especially by economists, for example, describing the growth of Alzheimer as a source of this. Because here, what you are describing is that the influence of the behavior, especially of the behavior of certifiers, is absolutely key. It may be over a long period of time, that is more than 10 years, absolutely puzzling and confusing. And therefore, the true causes is an unseen statistical variable, and we have, of course, visible information, but which could be misleading.
Yes, so that was the discussion we had with Regina about cause of that reporting practice. And as I mentioned, this has been a long debate, and it's really hard to really know how accurate it is. So, and this is mostly focused on which one is the underlying cause of death. So when we only look at one specific cause of death. So if we look at death that happen at young ages, so if you're in a car accident, then you know that car accident is most likely the underlying cause of death, and that tend to happen at younger ages. The main issue is then we get into the elderly population that tend to have sometimes 5, 6 different diseases. So as we see in Betty's presentation, the population is highly multimorbid past a certain age. So then you see, okay, you know, at the end the person has a pneumonia, and this is what killed the person. So that would be the immediate cause of death. But then the person also had some lower respiratory disease, also have heart disease, also have maybe a cancer, lung cancer, for example. It's like, okay, so, but without any of this condition, most likely pneumonia would not have led to a death. So which one is actually the underlying cause of death? And is it more the lower respiratory disease? Is it more the lung cancer? Or is it the heart disease? So trying to make sense of which one is actually the underlying one is extremely complex. There's some guideline in trying to navigate through that, and now they automized it. But it's still a judgment call. There's some study that tried to assess how the official statistics were accurate, and they did some autopsy and trying to understand on the sample. And actually what was on the death certificate was not really matching what was the conclusion of the autopsy. But of course you cannot do an autopsy on everybody that died. So the key question is, we had a lot of debate. So should we use cause of death analysis or should we not? I think it depends on how you want to use it, because I think it still represents a certain burden of disease, maybe not the complete burden of disease. We hope that if we look at like multiple cause of death, that we can have a better picture of what's happening. The exact causal pathway that was Betty's studies can be a bit misleading. So maybe not like what is reported is maybe not the right chain of event, but we might have at least an idea of multiple conditions that can have contributed to death. So that can give us at least a bit of a better idea of a condition contributing to a death. Might still not be perfect. And as we mentioned, it's still not representative of everything, all conditions that are present at the end of life. But it seems to match, seems to be associated with what we think was the causal pathway, what we think was the underlying process. So on this, we're trying to dig. It's still ongoing result. But yeah, this is how to change this practice and probably better training of the medical practitioner. But even that seems to be extremely complex, because if somebody have 10 different conditions, trying to find the right underlying one can become, it's a puzzle. Yeah.
Yes, but then a further question on that point, and I will stop asking question because I am absolutely incompetent in that field, and therefore I am just afraid that all the statistics I have been reading until now could have been misleading in my mind, at least. No, because I see always, I have seen always two dimensions in any cause of death. People are saying, okay, it's your heart, it's your respiratory system, which is the immediate cause. But of course, if you have been contaminated by the COVID, it's not the COVID that will kill you. It's something else inside your body, which, of course, at some point in time we stop, etc. And therefore, it's always very complex to see. Well, because there are different meaning of the causes. So something which we well known since Aristotle, that there is not only one cause, is just an illusion. But in fact, there are different category of causes, in fact, behind what you have been describing.
Yeah. For the first point, I would not say that all the cause of death statistics are wrong. Per se, I think there's still some pattern that we can see through them. So I would not like discredit fully what's happening in terms of cause of death. I would say that it might not be fully representative of the real underlying condition, but I think this is because it's a very complex question. So maybe this is one way to look into this, and is to look maybe at multiple cause of death and see like, okay, what is the full picture? But even that, as we can see, can be like a sample of actually what's happening. The way and then there's the multiple type of cause of death. So I think Aristotle was the premature versus more elder chronic condition that happened later in life. So this is of course depending on how you code them. So you can go very deep into what specific cause of death. I don't know how many thousands of code there's in the current classification, but we generally tend to group them into systems. So it can be circulatory system, respiratory system. So it's mostly cause associated with one specific system that fails. Sometimes you can go more deep and specify them a bit more. But this is also another question on how to best group them, because I don't think analyzing thousands of different small conditions also would help understanding what's happening if we go too much in details. There's some standard way of coding, but there's no one universal way of doing it. I don't know if that answered your question.
Yes, no, it's
okay.
You are precising. No, it's good. It's okay.
Yeah, I don't know if Cosmo and Betty, you have something to add. No, okay.
Let me look if there are further questions. I don't see hand rising, and therefore, because we are now since 19 minutes together, I think that if I want to be consistent with my promise to close the webinar, I would like to thank so much you, Marie-Pier, Cosmo, Elizaveta, because it was very, very interesting and pointing something which is, of course, key for us insurer when insuring mortality, because at the end of the game, it's not so clear what we are insuring. Perhaps we are more insuring the certifiers than the disk itself. Okay, so it's a joke. And I would also like to thank also who have organized the webinar inside SCOR, and thank also all the participants for their participation.
Thank you very much for inviting us. Nice.
Thank you.
Thank you so much.
Thank you. Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye-bye to all.
Bye.
Bye.
Bye. Zaying, so should I stay or it's
No, it's okay.
it's okay.
I'll send you, drop you an email, okay?
Perfect. We
For
keep in
your
touch.
different, how the meetings.
Perfect.
Okay,
We
thank
keep
you
in
very
touch.
much.
Bye bye. Have a
Thank
good day.
you.
A good evening.
Bye-bye.
Bye.
Bye-bye.